Today's class, we are going to discuss on the periodontal treatment plan. So what do you know by treatment plan? So treatment plan, such as like for all the different specialties, they have different treatment plans for each disease. Like dental care is pain, so they will be in conservative point of view, they will be dealing with, they'll be having the treatment plan is different. Like it will be either extraction or temporary restoration or root canal treatment or episectomy, surgical procedures. Like so, each specialty it has a different treatment plan for the disease. So, what do you mean by treatment plan? The periodontal treatment plan. So, what do you mean by that? The treatment plan for all any diseases, the treatment plan is the same. So what do you mean by treatment plan? Treatment plan is that it's like blueprint for the management of the case. Like your blueprint. നമ്മളിപ്പോ ഒരു വീട് പണിയാണ് അല്ലെങ്കിൽ നമ്മളൊരു എന്തെങ്കിലും ഒരു പ്ലാൻ ചെയ്യാണ് അതിനാണെങ്കിൽ നമ്മൾ എവിടെ വേണം അതിന്റെ പ്ലംബിംഗ് ലൈൻ എവിടെ വേണം ഇലക്ട്രിക്കൽ ലൈൻ എവിടെ വേണം അതിന്റെ ഓരോ സ്റ്റെപ്സ് ഓരോന്നിനും ഓരോ ട്രീറ്റ്മെന്റ് പ്ലാൻ അതിൽ ഓരോന്നിനും ഒരു ബ്ലൂ പ്രിന്റ് ഉണ്ടായിരിക്കും നമുക്കിപ്പോ പണിയുന്ന വീടിന്റെയോ അല്ലെങ്കിൽ എന്തിന്റെ ആണെങ്കിലും നമ്മളൊരു ഇപ്പൊ ഒരു ക്ലിനിക് ആണെങ്കിൽ ഡെന്റൽ ക്ലിനിക് ആണെങ്കിൽ നമ്മൾ അതിന്റെ പൈപ്പ് എവിടെ പോകണം ചെയർലെസ് ഇത് എവിടെ വേണം അങ്ങനെ ഒരു ട്രീറ്റ്മെന്റ് പ്ലാൻ നമ്മൾ ഡിസൈഡ് ചെയ്യുമ്പോൾ ഒരു ബ്ലൂ പ്രിന്റ് നമ്മൾ ഉണ്ടാകും. So that blueprint is called as a blueprint for the management of the case. Like you're going to do this treatment first, you're going to do this treatment second, you're going to do this treatment third. നമ്മൾ ഒരു പ്രോട്ടോകോൾ ഉണ്ടാകും. ഫസ്റ്റ് ഇതാണ് ചെയ്യേണ്ടത്, ഫസ്റ്റ് സ്കെയിലിംഗ് ആണ് ചെയ്യുന്നത്, അല്ലെങ്കിൽ ഫസ്റ്റ് പേഷ്യന്റ് എഡ്യൂക്കേഷൻ, മോട്ടിവേഷൻ, ഡയറ്റ് കൗൺസിലിംഗ്, ബ്രഷിംഗ് ഇൻസ്ട്രക്ഷൻ, അങ്ങനെ പലതും നമ്മുടെ ഓപ്ഷൻസ് വരും. സോ വി ആർ ഡിസൈഡിങ് ഓൺ ദ ഓപ്ഷൻസ് ഓർ വി ആർ deciding on what to do first. 1, 2, 3, 4, 5, 6. That is your blueprint for the management of the case. So after you reaching your diagnosis, like you confirm that this patient is having this disease, or your diagnosis, like for example, chronic periodontitis, your diagnosis to the final diagnosis that it is chronic periodontitis. So chronic periodontitis, then patient will be having mobile tooth or swollen gums or pus discharge or abscess or pain or whatever it is. Then you come to the prognosis. Prognosis is the course, duration and outcome of the disease. Then after prognosis, then you are deciding on the treatment plan. What treatment this patient needs. So number treatment plan, it should be as such that it should be useful for the patient, and you should be relieving the patient of symptoms or signs of pain or inflammation or swelling or bleeding, whatever it is. So you should plan your treatment in such a way that the patient is relieved of his or her symptoms. So what is a treatment plan? It is a blueprint for case management. So you are making a chart that first this has to be done, first this has to be done, second this, third this. You are planning accordingly. So before going with the treatment plan, you got to take decision regarding what has to be decided. So first you are planning that whether tooth has to be extracted or you can restore it. Extractions mainly it is indicated grossly decayed teeth or mobile teeth, or the patient complains of pain or something, so something like that. So you will be deciding on whether to go for extraction or whether to restore the tooth. Restore the tooth, if it is a deep carious lesion and things like that, you got to go for endodontic treatment or root canal treatment, or further treatment like if there is any periapical abscess or infection like that, you need episectomy or surgical procedures. So decision regarding extraction or restoration, you are restoring or you are removing, so that has to be done. Then the treatment of periodontal pockets, you did the charting of your periodontal index, so pockets are there. So treating the pockets, you are deciding on whether to go for surgical management or whether to go for non-surgical management. Surgical management, you all know, like you open up, you do a flap surgery like modified Goodman or typically displaced or coronal displaced, undisplaced flap, things like that. Or non-surgical. Non-surgical, if it is a pocket, periodontal pocket more than 4 millimeter only, you think of surgeries. Normal gingival sulcus depth is 2.04 millimeter. So if there is a periodontal pocket of 4 millimeter, you will be always in a dilemma whether to go for a surgical management or whether to go for a non-surgical management. So up to 4 millimeter of periodontal pocket, you always go for non-surgical management. So what are things you do in non-surgical management? Non-surgical management, you can do scaling and root planing. You can do subgingival curettage, whatever it is. You are not opening up the flap and you are not placing any suture. That is a non-surgical way of management. So if it is a small pocket like 4 mm pocket or 3 mm pocket, you can always go for non-surgical management, such as deep cleaning like curettage or root planing and things like that. So you got to decide on whether to go for surgical management or non-surgical management. Then the third is need for occlusal correction. Like sometimes there will be a trauma because of sometimes some areas only the cusp will be touching. So occlusal correction, because trauma from occlusion is another problem. We all face patient complaints of pain or mobility, but you can't see any caries, or sometimes you won't be able to diagnose a periodontal pocket also there. So need for occlusal correction, that you do coronoplasty, that is selective grinding of the tooth by marking it. Then you want to decide whether you got to do a temporary restoration or a final restoration. If it is a deep caries lesion, you always go for a temporary restoration. And if it is not that deep, caries is present, you go for a final restoration. You always note that you are going for temporary restoration and your final restoration. Sometimes everyone will be telling that it's a permanent restoration. Nothing is permanent in this life. When your tooth is not permanent, you are not permanent, nothing. So temporary means, okay, it has to be removed or it has to be changed. That's why it is temporary step cap arrangement, things like that. So you like that opposite is permanent, but in our case, the filling, it's not permanent, nothing is permanent. So temporary and your final restoration. And fourth, fifth is the need for orthodontic treatment. Sometimes the patient will be having a single tooth malocclusion, or sometimes the tooth might be rotated. Sometimes the patient will be having crossbite on one side. So you want to evaluate whether the patient needs a minor orthodontic correction. So if it is there, you got to decide whether you do the treatment, orthodontic treatment, minor orthodontic correction, not the complete orthodontic treatment by moving the tooth. Sometimes you need a slight rotation or minor orthodontic correction. Sometimes you need that. So you got to decide on that. And sixth is you got to decide on whether endodontic therapy is required. The patient will be having pain, or patient will be having a periapical abscess or sinus discharge. So you will be deciding on whether to go for endodontic therapy, that's the root canal treatment. Then seventh is the aesthetic consideration, because you should always keep into consideration patient's aesthetic value, because everyone will be having difficulty because if their teeth is extracted and they look ugly, things like that, everyone will be having aesthetic consideration more than functional consideration, because everyone will be needing the front teeth, like canine to canine, or things lower, upper to lower canine to canine. When they smile, they need teeth. Posterior teeth, they're not bothered mostly, because posterior teeth, it's in a functional, or you need it for grinding and occlusion. But എല്ലാവരും ഭംഗി എന്നുള്ള കോൺസെപ്റ്റിൽ ഇപ്പോൾ ഒരു പല്ലാണ്. So you got to always keep in consideration of the aesthetic consideration of the patient, because sometimes the grade 3 mobility or fracture to upper anteriors ഉണ്ട്, രണ്ട് പല്ലെടുക്കണം, ഒരു പല്ലെടുക്കണം എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ patient will be having difficulty, or patient will be having ഒരു വിഷമം ഉണ്ടായിരിക്കും മനസ്സിൽ. So you got to keep that in consideration, whether to extract it or whether to do a provisional splinting or temporary splinting and retain it. And once the inflammation, pain, or swelling, bleeding, everything subsides, then you think about the other procedure. Then the sequencing of therapy. Sequencing of therapy means which one you should do first, which one you should do second or third, fourth. That sequencing, you should always keep in mind 1, 2, 3, 4. This has to be done for this patient. So before proceeding for all treatment, you should do the decision regarding all this. And Please note that except for emergencies like a fractured tooth or grade 3 mobility or Evel's tooth or like tooth with grade 3 mobility and things like that, no treatment should be started until the treatment plan has been established. If you're not establishing a treatment plan, don't go for any further treatment, because unless and until it's an emergency like fracture or pain or things like that. And the purpose of your periodontal treatment should be the maintenance of a functional and aesthetically acceptable dentition throughout the life of the individual. നിങ്ങളുടെ ട്രീറ്റ്മെന്റ് പ്ലാൻ ആസ് സച്ച് നിങ്ങളുടെ മനസ്സിലുണ്ടായിരിക്കുന്ന പേഷ്യന്റിനെ കൺവിൻസ് ചെയ്ത് മനസ്സിലാക്കേണ്ടതാണ്. പേഷ്യന്റിന്റെ functional occlusion നമ്മൾ മെയിൻറ്റെയിൻ ചെയ്യാൻ പറ്റണം. നമ്മൾ മെയിൻറ്റെയിൻ ചെയ്യുന്ന പേഷ്യന്റ് ഷുഡ് ബി ഏബിൾ ടു മെയിൻറ്റെയിൻ ദ ഫങ്ഷണാലിറ്റി. അതായത് നമ്മൾ ഗ്രൈൻഡിങ് ആയിരിക്കും, chewing ആയിരിക്കും, even your speech, the phonetics. So everything has to be considered and even aesthetically acceptable condition, because pallu ponni nikkunna aarkku ishtamundavilla, pallu ingane gap aayittu nikkunnu angattonnu aarkku ishtamundavilla. So throughout the life of the individual, sometimes you get a complicated like compromise case like grade 2, whether you should save it, whether you should extract it. So you should plan that accordingly. And main thing, sometimes your treatment plan, you will be thinking of extraction of a hopeless tooth, but that has to be postponed if the 3 criteria are not satisfied. If it maintains a posterior vertical dimension of occlusion. What do you mean by vertical dimension of occlusion? Also, vertical dimension of occlusion in the vertical dimension is measured from the tip of the nose to the prominent portion of the chin. If your vertical dimension is more, what happens? Your face looks elongated, negatively. And if your vertical dimension is less, your face will be like old people. So you got to maintain the posterior vertical dimension. So if the tooth is in that, your hopeless tooth, we are diagnosing the hopeless tooth, it maintains supported posterior vertical dimension of the occlusion, please postpone it. And if it is in a second, if it is located in the aesthetically critical area, so frontal if it is located in the aesthetically critical area, you always think of postponing it, because after the future lengia. And if the periodontal surgery of the adjacent teeth is required, if the periodontal surgery of the adjacent tooth, for example, 1-1 mobility ആണ് നമ്മളത് extraction ചെയ്യാൻ പോകും, but you need a surgical management of 1-2 and 2-1. So always wait for postponing. And what are the different phases of periodontal therapy? So many different phases, like your blueprint, you have so many different phases. So what is a preliminary phase? That is a emergency phase. That is a first phase, whether you're going for such treatment that we told earlier, deciding what to do first. Then second is a Etiotropic phase, or the phase 1. Phase 1 is an important phase in our periodontal point of view, because phase 1, if you do your phase 1, then phase 1 thoroughly, then all your other treatment or other phases, it will be easy for you. But maybe നമ്മുടെ തിരക്ക് കാരണോ അല്ലെങ്കിൽ നമ്മുടെ അശ്രദ്ധ കാരണോ no one gives such important to phase 1. phase 1 നമുക്ക് കുറേ കാര്യങ്ങൾ നമുക്ക് ചെയ്യാനുണ്ട്. അതായത് phase 1 വരുന്ന കുറേ കാര്യങ്ങൾ we will deal it as a separate chapter in the next class or something like that. ഈ ക്ലാസ്സിൽ സമയം ഉണ്ടെങ്കിൽ we will go for it. അല്ലെങ്കിൽ നമ്മൾ സെപ്പറേറ്റ് ക്ലാസ് ആയിട്ട് we will take it later. phase 1 is very important. You got to do so many things in phase 1. That mainly the patient education and things like that. You do motivation the patient, you do brushing instructions and things like that. Everything comes in phase 1. And after phase 1, you wait you evaluate how the patient responds or how the tissue responds to your phase one. Phase one, you do mainly counseling, like counseling, brushing instructions, scaling, root planning, and etc. 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 So after your phase one, you have to evaluate the response of each phase. Like if the patient reported you with severe calculus or swollen gums or pain and things like that, or pain or bleeding gums, and you know that the patient is not maintaining their oral hygiene properly. So what you do is that you are going to do the phase one. Phase one means mainly use scaling, root planing, not the surgical management. Scaling, root planing, and you evaluate how the tissue heals, how the tissue responds, whether bleeding is reduced, redness is reduced. And the main thing is that you want to check whether patient is maintaining their oral hygiene properly. Oral hygiene അവർ മെയിൻറ്റെയിൻ ചെയ്തില്ല എന്നുണ്ടെങ്കിൽ and you're proceeding with further treatment, your treatment has all the chances to be utter failure. അതാണ് phase one ഇമ്പോർട്ടൻസ് അത്രയ്ക്ക് ഉണ്ടെന്ന് പറയാം. നമ്മൾ തിരക്കിൽ ചിലപ്പോൾ you start your practice, you have so many patients, you don't give much importance to that, but the importance is at phase one, then all your other treatment, your surgical or respiratory or all this treatment will be very easy for you. Otherwise, what the problem is that you do phase one, you recall the patient after 3 days, you are not checking for tissue response, healing or bleeding or whatever it is. You again straight away proceeding to phase two is a surgical phase. And problem is that you are doing surgery, you are doing flap surgery or whatever it is, and if your patient is not maintaining their oral hygiene properly, your treatment is going to be a failure, because all the problems happened because the patient was not maintaining their oral hygiene properly. The severe calculus, plaque, and all those things. And because of that, the patient had these problems. And you did the scaling, next day or after 3-4 days, you doing surgical management, you're not evaluating the patient, how they are maintaining, how they are brushing it, or things like that. And you proceed directly to phase two. The problem is that your phase two surgical management, the patient won't maintain, there will be again plaque deposition, things like that. And not in the long run, in the short run, your treatment is going to be a failure. So the patient comes back to you and tell the doctor, you did surgery, you told me that after cleaning you do surgery, and I did like that. And my treatment, like the tooth is mobile or whatever it is, the treatment will be a failure. And you will have to cut a sorry face in front of the patient. So educate and motivate the patient, that's very important. After phase one, before phase one, and after phase one, you educate, motivate, and things like that. Then after phase two also, there is evaluation. After each phase, there is evaluation of response. How the tissue reacts, how's the patient responding to the treatment. So after your surgical management, you keep recall visit. After your surgery is over, first month recall, third month recall, 6-month recall. Then if the patient is maintaining, then you ask the patient to do maintenance phase every year. So after phase two also, you got to evaluate the patient. And third is the restorative phase or the phase three therapy. So after your surgical management, the patient is maintaining, the tissue response is good, everything, the tissue shrunk well after your surgical management, then you can replace with removable partial denture or fixed partial denture or cast partial denture or whatever your implants, everything has to be done in the phase three, that is the restorative phase. And after phase three also, you got to evaluate the tissue response, because sometimes if crown is impinging on the mucosa, it will create problems. So after phase three also, you got to evaluate. Then phase four is the maintenance phase. Maintenance phase is that you want the patient, or you should make sure that the patient maintain their oral hygiene properly. So this, though it looks simple, but it has a big role in maintaining the patient's oral condition. So what all comes in the preliminary phase? You deal mainly with emergencies. Emergencies like dental or periapical abscess or pain, periodontal abscess or pain, and other things like the extraction of hopeless teeth and provisional replacement if needed. Only these three things comes in the preliminary phase or the emergency phase. You want to relieve the patient of dental or periapical pain, any periodontal abscess, an extraction of hopeless teeth, and provisional replacement if needed. We will be dealing in phase 1 in a separate chapter. So just go through this. Etiotropic phase or the phase 1 therapy. It has so many other names. It is otherwise called as course-related phase or hygienic phase or preparatory phase, non-surgical phase, initial phase. So many other names are there. So what are things you do in this phase 1 therapy? The plaque control and patient education. You are going to educate, motivate the patient. And diet control, because if the patient is eating lots of sticky foods, then you know that the chance of plaque accumulation is more, and because of the plaque, so bacterial load will increase, and it affects the gingival tissues and periodontal tissues in the long run. So plaque control and patient education is must. Diet control, you should advise the patient and counsel the patient regarding diet control. Then you go for scaling and root planing. Do scaling. Scaling is a progingival removal of plaque and calculus, and root planing is a subgingival removal of calculus from the tooth root surface. So you want to remove the subgingival calculus, you want to smoothen the root planing with the curettes, and make this helps in reattachment and correction of restorative and prosthetic irritational factors. Sometimes class 2 restorations or class 5 restorations causes food impaction or plaque accumulation. Directly or indirectly affects the gingival tissue, and even prosthetic irritation factors like the class or the RPD, or even your crowns, the bulky crowns causes foot impaction and causes gingival irritation. And restoration of the caries teeth, that's a temporary or permanent. It shouldn't be called as permanent, it should be called as a final restoration. Just to note, I written temporary and permanent, but it's not a permanent restoration, temporary or a final restoration. And in phase 1, if the patient is having severe swelling, bleeding, and things like that, then you always think of antimicrobial therapy, that whether the patient requires any antibiotics or any anti-inflammatory, you got to take into consideration whether to give antimicrobial, either local antibiotic, that is local drug delivery, or systemically the patient is taking the tablet. For local drug delivery, for particular local lesion, and you are able to do tetracycline fibers or things like that. So you can go for local antimicrobial therapy. And occlusal therapy, like if any traumatic occlusion is there, trauma from occlusion is there, we got to do the occlusal therapy, that's a coronaplast. And minor orthodontic tooth movement, if requires, like if there is a crossbite or if there is a gingival recession and things like that, always go for a minor orthodontic correction. And provisional splitting and processing, if it affects the aesthetic area of the face, you got to do a provisional splitting. You split the tooth, and after your treatment, everything you can remove it. That's a provisional splitting, and the process is, if required, like if 1-1-1-2 or 2-1-2-2 is extracted in the upper or lower region. So for aesthetic wise or an appearance wise, you can go for a provisional process also. Evaluation of the response to etiotropic phase. This is a very important part in your phase 1 therapy. You got to evaluate how the tissue responds, how the patient responds after your phase 1 or the etiotropic phase. You got to recheck the pocket depth. You want to check whether the pocket depth is reduced after you do scaling and root planing. You want to check whether the gingival inflammation is reduced after you did the scaling and root planing, and the amount of plaque and calculus and hair is present. Like after scaling, if the patient is maintaining, the plaque will be less, or again the calculus formation takes place very fast. So depending on the response of phase 1, the treatment plan may change. If the patient is maintaining very well, okay, go for straight away, you can go for phase 2 therapy. And if the patient is not maintaining their oral hygiene properly, you got to wait. And sometimes your treatment plan, you got to change your treatment plan accordingly. In this case, you can see there is on the top left side and top left lower side, top left and lower side, you can see the inflammation of the gingiva. You can see it on the buccal side between 5 and 6, and at the lingual side of 3, 5, and 3, 6. You can see a swelling. And after you do the thorough scaling, only scaling has been done, you can see the difference. The swelling has gone, but there is a space created because of the swelling. There will be bone loss and pocket formation. You do the normal scaling. You can see that. And next is the phase 2 or the surgical phase or the corrective phase. All the periodontal therapy, like your surgery, the flap surgeries like undisplaced or modified with apically displaced, coronal displaced, your grafting, subepithelial connective tissue graft, gingival grafting, or vestibular deepening procedures, lateral pedicle graft, double papilla graft, all surgical management of the periodontal surgical management comes in phase 2, including placement of dental implants. Implants placement comes in surgical phase. And other thing comes in is endodontic therapy. Endodontic therapy is that you do observation and you go for a episectomy. That procedure comes in phase 2. And phase 3 is mainly the restorative phase. Restorative phase or phase 3 therapy. What comes is that the temporary restorations you're done in your preliminary phase or phase 1. If it is asymptomatic, patient does not have any complaint and things like that, you go for final restoration. You remove the temporary restoration. Sometimes you leave the base layer, top of the dentin and the pulp chamber, you leave the layer, you do a final restoration. And you can go for fixed or removable processes, like sometimes when extraction is done, and you can go for a fixed partial denture or removable partial denture and things like that. So in phase 3, all these things comes under. And evaluation of response of the restorative phase, because you want to check after you do a normal class 5 or class 2 filling, you want to check the, and even crowns or whatever it is you're placing, you want to check the periodontal condition, how the tissue reacts, how the patient maintains and things like that. The last is a phase 4 therapy or the maintenance phase, or it's otherwise widely called as a supportive periodontal therapy. What will comes in there? In maintenance phase, periodic rechecking for plaque and calculus. So all these things like phase 4 you do after phase 1, phase 4 you do after phase 2, phase 4 you do after phase 3. So after each phase is 1, 2, 3. After each phase there is a maintenance phase. You are doing periodic rechecking for plaque and calculus. You are checking the gingival condition, whether the pockets is reduced, whether the inflammation is reduced, and you always check for occlusion because all the teeth has to be in function, and you have to check for whether the mobility has increased or reduced. Because after each treatment, and you start with the grade 1 mobility, and after you remove the plaque calculus and things like that, and you want to evaluate the tissue response, so you'll be seeing that mobility has been reduced and things like that. And if there is any pathologic changes, that also has to be noted in the phase 4 therapy. So what are the preferred sequence of the periodontal therapy? It's in a nutshell, so you can explain it once a question comes for you. University exam, you can see the arrows. So after emergency phase, that is the preliminary phase, you go for the etiotropic or the phase 1 therapy. Then after phase 1, there is a maintenance phase. You want to evaluate whether the patient is maintaining their oral hygiene properly, how the tissue responds, whether your gingival tissue or periodontal tissue, how it responds after your basic phase 1 treatment. And after that, there is a surgical and restorative phase. You can see that the surgical and restorative phase, after each phase, the arrow goes up and down. So after etiotropic, the maintenance phase. When you go for the patient maintains well, everything is fine, you go for surgical phase. After surgical phase, there is a maintenance phase. You have to see again the patient maintains the tissue response. Phase 3, restorative phase. You can see that arrow going up and down. So after each phases, after etiotropic phase, after surgical phase, after restorative phase, there is a maintenance phase. Maintenance phase has a big role in our periodontal point of view, that if you're not maintaining, if the patient is not maintaining your oral hygiene properly, you're going for other treatment, your treatment is going to be a failure. So it will be the failure of the treating dentist or dental surgeon or periodontist, whatever it is. So you got to be thorough with your diagnosis, you have to be thorough with your prognosis, and the main thing you should, like, രാത്രി ഉറങ്ങിയിട്ട് ചോദിച്ചു കഴിഞ്ഞാൽ ട്രീറ്റ്മെന്റ് പ്ലാൻ ഷുഡ് ബി എ പക്ക ട്രീറ്റ്മെന്റ് പ്ലാൻ യു ഷുഡ് അഡ്വൈസ് എ പേഷ്യന്റ്. And small advice, your treatment plan or your charges or whatever it is shouldn't be different for each patient. So charging a patient for flap surgery, you're charging rupees 1,000. It has to be 1,000 for all the patients. For poor patients, okay, you can do free treatment or whatever it is. But if one patient comes, you charge 1,000, other patient comes, you charge 3,000, other patient you charge 5,000. If you are charging like that, there is no end. Your treatment will end soon. Your, not the treatment, your practice will end soon. Because the patient evaluate the doctors very well nowadays, because of facilities of the Google, everything they will search in the Google and come for your treatment. So if the doctor is not sound enough or doctor does not have a sound knowledge, they will easily know that, because they will be having lots of questions, because the Google will be answering them and they will be in a confused state. So they come to a doctor for treatment. So you should have the basic knowledge and you should have a thorough knowledge of what you are going to do to this patient. Once you reach your diagnosis, conclusion, final diagnosis, then your prognosis, you will tell that this teeth has to be extracted, this tooth has to be filled, this tooth has to be endodontically treated, or you got to replace it, things like that. Then you go for the periodontal treatment. So periodontal treatment point of view, you got to explain in detail the patient with all the armamentarium you have, that you diagnose the patient, you have a prognosis, a treatment plan. Treatment plan, again, it is a wide area. Treatment plan, you should always tell about the appointments, how many appointments you require, like how many sittings you need, scaling 1 sitting, surgery 4 sittings or 5 sittings, things like that. So if the patient requires 8 sittings or 10 sittings, explain in detail that you need such sitting for this, for this, for this, and explain in detail to the patient that if they are maintaining their oral hygiene properly, your treatment is going to be a success, because the doctor will do the best he can do. And if the patient is not maintaining and then blaming the doctor, it's not a easy thing, or it's not easy on the doctor's part. So you always convince the patient, always educate the patient, always motivate the patient that they should maintain their oral hygiene properly, especially in periodontal point of view. If they are not maintaining their oral hygiene properly, then your treatment is going to be a failure, and patient won't have any good doing all these multiple appointments and visits and things like that and spending lots of money. So education and motivation and informing the patient how many appointments is required, how much charge will come for the entire procedure, or each procedure separately, entire procedure, how much charge will come. And after this you have the maintenance phase, or after this you have surgical phase, or after the again maintenance phase, and periodic recall and visits for checking whether patient maintains their oral hygiene, the tissue response, the pocket depth reduction, and things like that. Everything has to be taken care and explain in detail to the patient very well in advance before you start the treatment. Otherwise, once you start the treatment, when you change the plans, then the patient will know that the doctor is not sure about the treatment, or the patient will think that this doctor is doing something to get more money from me. So once you see the radiograph, once you see the patient, once you come to a conclusion or a diagnosis, then you explain to the patient 1, 2, 3, 4, 5 what is happening, what has to be done, how many appointments, how much charge will come after, like if you want to replace a tooth, you will tell them that after surgical management, you will wait for 1 or 2 months and you replace it. For that, this much charge will come. All thing has to be explained in detail to the patient. If you are not explaining in detail to the patient, you directly go for surgical management. Like sometimes some people do that. First sitting comes the patient, they do the scaling. First sitting, the same sitting go for a surgical management. How many people does that? The problem with that, you're doing the same treatment, but on the same day, that is a problem. Usually, you do a scaling, you wait for 7 to 10 days, you evaluate the patient, you want to check whether the patient is maintaining their oral hygiene, how the tissue response, the bleeding has been reduced, or the pain has been reduced, or swelling has been reduced. Then you go for a surgical management. Same day you do scaling, same day you do surgery. You don't know whether how the tissue responds, how the patient cooperate or patient maintains their oral hygiene. So you won't know that. So you will be dealing with things like that. And ultimately what happens is that your name will be spoiled. So explain in detail to the patient what all things has to be done very well in advance. That's what we call treatment plan, is it blueprint for case management. You take the patient visited you 1 month before. In your case history, everything has been written, like advice scaling, root planning, brushing instructions, everything one by one, everything is written. Then if anything wrong goes, nothing you can do, because patient, they are not maintaining their oral hygiene, they don't do anything. So it is up to them to decide whether they want a good treatment or they want a result for their treatment. So this class I will conclude, but the phase 1 therapy that we told earlier, phase 1, this we take it as a separate class because so many things comes in that. Phase 1, the main thing is that plaque control, based education, diet control, the scaling and root planning, and corrective of defective restoration. Like I told you, like class 5 or class 2 restorations or any irritational factor, sometimes because of the prosthetic denture or crown, there is foot impaction or foot accumulation and pocket formation and things like that. That has to be corrected. Restoration, and whether the patient requires medications. Like sometimes you can see the patient, say the patient will be having multiple abscess or things like that. It came to you. So such type of patients, you always have to prescribe medication. So you should evaluate whether the patient needs a systemic medication, because with the generalized condition involving many areas, and you go for systemic medication. If it is pertaining to the local area, like between 1, 4, 3, 4, 3, 5 or 3, 5, 3, 6 regions, and particularly one area, you can always think of local therapy. What does it mean by local therapy? Local therapy is either local drug delivery, local like antibiotic injection and things like that. Mainly do the tetracycline fiber and even your chloroxidine chips, that has to be local, the metronidazole gel, heterodox and things like that. So many things there for local delivery, local drug delivery. Sometimes even you irrigate with the medication. The particular area only is maintained. So you got to do that. Then minor orthodontic tooth movement if it is required. And professional splitting and processes, like told earlier, if it affects in the aesthetics or if it affects the vertical dimension. So wind up your today class. So what all things you have taken today? What is the treatment plan? Treatment plan is a After you come to diagnosis, prognosis, you come to the final treatment plan. It's the blueprint for the case management and decision regarding the following are taken, whether you need extraction or restoration, whether you need surgical or non-surgical treatment, whether you require occlusal correction, whether you require temporary or final restorations, minor orthodontic treatment, endodontic therapy if required, aesthetic consideration, and you plan it accordingly, the sequencing of the therapy. And except for emergencies, you don't do any treatment because until the treatment plan has been established. And the purpose of it should be the maintenance of the functionally and aesthetically acceptable dentition throughout the life of the individual. And extraction of opus tooth can be postponed if it maintains a positive vertical dimension, which is located in an aesthetically critical area, and if the periodontal surgery of the adjacent tooth is required. And this we dealt elaborately with the phases of periodontal therapy. It's a preliminary phase of the emergency phase, then the etiotropic phase of the phase 1 therapy. There are other names, course-related initial, non-surgical therapy, hygienic phase, or preparatory phase. All those names comes for phase 1 therapy. And after each phase, you do a evaluation. That's a phase 4 therapy, that maintenance phase. You want to see whether the patient is maintaining their oral hygiene properly, things like that. Then if they're maintaining the oral hygiene properly, then you go for a phase 2. And after phase 2 again, you are seeing whether the patient is maintaining, then you go for phase 3. And after phase 3 again, you are evaluating the tissue response, you go for phase 4. So phase 4 has a major role. And preliminary phase, it should be the treatment of dental or periapical pain, periodontal abscess, and extraction of hopeless teeth. And phase 1, we told earlier, main thing comes is diet control, plaque control, instruction, patient education. These are very important. Then you go for scaling and root planing, correction of restorative and prosthetic irritational factors, restoration of caries teeth, either temporary or final restoration, antibiotic therapy if it is required, occlusal therapy, minor orthodontic treatment, provisional splinting is already told earlier. And after evaluation of the response of your phase 1 therapy, you check for pocket depth reduction or gingival inflammation reduction, the plaque and calculus care is everything. And depending on the phase 1, you see how the patient responds to the treatment. Then the surgical phase, all periodontal therapies, mainly all surgical management and implants, then endodontic therapy, mainly the root canal observation. Then you go for phase 3, that's a restorative phase. All your final restorations and fixer and removal processes are kept. Then after that, you go for evaluation of the response to the restorative phase, the periodontal examination. Then there is a important thing, the phase 4, a maintenance phase or a supportive periodontal therapy. You check periodically for plaque and calculus, the gingival condition. We told earlier the reduction periodontal pocket, reduction in inflammation, occlusion, tooth mobility, other pathologic changes if at all there. And this is a preferred sequence of periodontal therapy. After your emergency phase, you relieve patient of pain, then you go for etiotropic phase or phase 1, you mainly do scaling and things like that. Evaluate, let's maintenance phase. Tissue response is good, you proceed with surgery. So after surgery, again you do maintenance phase. You want to see if the patient is maintaining, then you go for the restorative phase. That's a fillings or crowns or bridges or whatever it is. Then again, maintenance phase. So it's important in your theory point of view, and it is important in your clinical practice point of view. Treatment plan has to be thorough or pakka by the doctor. It has to be very well clearly explained to the patient. So in the next class, I will see you with phase 1 periodontal therapy. We will go in detail with the phase 1 therapy. Thank you.